And it is a pleasure to be with you all today and to celebrate you, our physicians, and the incredible work that you do. We could easily have many more names up here than we do, but we will just start with the nominations we have. We have Kelly Mansfield. She is our chair of our Nurse Engagement Council, and she has been leading the efforts for the last 3 weeks to gather all the applications, to work with the council, to review the applications, and to select the winners.
Good morning. It's great to be here. I just wanted to start off by saying we had an amazing group of people that were selected this year, and it was a really difficult decision. One of the things that I want to say about all of the physicians and everybody that was nominated was that we saw a common theme, which was that everybody had stories of how well our medical team worked with the nursing staff, and I think that that's one amazing thing about working here at Primary Children's is the relationship that nursing and medical have together, and that was a common thread that really was illustrated throughout this process. So just to start with, we'll start with our fellow nominees. And you can see in both categories, we had a lot of nominees from many, many different areas, and it was really exciting to be able to read about all of these different fellows and the ways that they have had impact within our hospital. So our nominees were Sagar, who is a plastic surgery fellow, Tim Olson, Salim, Christopher Ars, Chris Wilkerson, and Liz Quigley. It was just a really great group and a very difficult decision. So for Fellow of the Year or Resident of the Year, our winner was Salim, who is fantastic. So I work with Salim in the PICU and CICU, and I think he's amazing. He is not able to be here today. He actually finally decided to take some vacation time and he said, if I had known earlier, I would have changed it, but we felt like it was important for him to have some time. So Rebecca is going to accept that award for him, and we will present that to him later on. So. And then here, from his application, these are some of the things that were said about Salim. One of my favorites is this quote on trust that says, "When Salim's on service, I know I'm working with a team member I can trust who will do the right thing and has the knowledge to make appropriate decisions quickly." And I think everybody who knows Salim can validate that that's true. In excellence, they said one of his strengths as a practitioner is the ability to stay abreast of current research and apply it to patient care. In mutual respect, they said Salim listens to the entire team as well as family members before making patient decisions. He's helped the nursing staff provide culturally competent care and bridge culture gaps. And there was a specific story regarding how Salim had actually helped us with a patient that was from out of the country and sat down with them and really helped nursing and the physicians understand the cultural issues that we needed to incorporate into that family's care. And then integrity, it says his willingness to speak up is a testament to his dedication to his patients and provides a great example to the staff on the unit. So we have a huge list of attendings that were nominated. So I'll let you guys read through this list, but it's such a wide base of the hospital that was nominated, and that was really exciting. There were some interesting things I found from this group. I don't know if anybody's aware of this, but we actually have a veterinarian in the hospital that is one of our attendings. So that was an interesting thing to learn. But this is a fantastic group, and again, so many stories of how they work with our nursing staff. So our winner in nominees for this year is Teresa Such-Nybar. So again, from the application, when Dr. Such-Nybar says she will do something, you can rest assured it will be done. She is the queen of follow-up. Excellent. She serves on the board of the Brain Injury Alliance of Utah as the pediatric specialist in brain injury. In mutual respect, she will often tell a patient family they're part of the rehab team and their voice will be heard as decisions are made concerning their care. And with this, there was also a specific story of a patient who had some very specific needs and how she was able to address those and create a discharge plan that kept that patient safe at home. Zero harm. Dr. Such-Nybar puts the safety of her patients as a top priority. She works with nursing, therapy, social work, and case management to create a safe discharge plan. So I just want to say thank you and congratulations to all of the nominees. Such amazing thing as a nurse to work with hospital staff that is so fantastic, and we appreciate as nursing all that you do for us. So thank you.
Thank you, Kelly, and congratulations again, Terry, for an outstanding and well-deserved award. It's my pleasure this morning to present the James Bale Award in Teaching. And we started this award about 9 years ago, and the people who have received the award have been exemplary, and the recipient today is exemplary. It was established to honor both the University of Utah pediatric faculty for their teaching, and particularly to honor the contributions of Jim Bale, who I have known, I think when I calculated this morning, for nearly 40 years. And so it is the recipients each and individually and collectively have demonstrated outstanding contributions in education following the leadership of Jim Bale. We're pleased to honor today Dr. Wendy Hobson. And would you join me in the first round of applause? So this is the reason why. She is really an outstanding and passionate educator. Shortly after she joined us in 2003, she developed a standardized education curriculum for the outpatient clinics. And seeing the need for faculty to enhance their teaching skills, she, along with others, established APPLE, the Academy of Pediatric Educators, which was really the first such academy here at the University of Utah. She has continued to grow and expand, and she's now in the Vice President's Office for Academics with Dr. Rory Hume, and prior to that with our colleague Carrie Byington. And she is the Assistant Vice President for Education and Faculty Development. And in that setting, she founded then the university-wide Academy for Health Educators, which brings together not only the College of Medicine, but also the College of Health, College of Pharmacy and Nursing, and the School of Dentistry. She's recognized as a national leader in pediatric education, chair of the Community Access to Child Health Committee of the Academy of Pediatrics, faculty team member of Pediatric Association Education Scholars Program, and also the associate editor of MedEd Portal, a online vehicle for sharing experiences in pediatric education. So for your passion, your tireless efforts to create a culture of educational excellence, we're pleased to present you with the James Bale Award for 2018, and we're fortunate to have Jim here today. So Jim, would you join me? Wendy, would you please come up? And I think it's only entirely appropriate to have Jim hand the award to Wendy. Schunk, you're up. Schunk? Oh, he wants an introduction?
No, he wants me to run the, oh, goodness, it's bad. Okay, I think I can do this. I'm only here every week. You'd think I could do this. Okay. Schunk, I think we're on.
Obviously, today demonstrates we have much to celebrate working in this hospital. And along with the awards given to the physicians, there's the award given to the program, that is our accreditation program, our CME program, and thank you to Joyce and Janelle in particular. I just want to encourage you, number one, to give feedback to them, and when they do solicit feedback, it's very important. We can't continue with accreditation unless feedback's given. And they do take the feedback about grand rounds very seriously, so I want to read with you some feedback that occurred the last time I gave grand rounds. If Schunk ever gives grand rounds again, he should be limited to 15 minutes. Signed, Ed Clark and Jim Bale.
I think we said 12.
So this is why we have the format we do today. I will limit myself to about 15 minutes, and then my co-conspirators will have their time as well. Today's topic is pediatric urinary tract infection. We will focus on risk stratification, that is, who's likely to have a UTI, diagnosis and initial treatment. And in particular, this is not a rehash of febrile infant literature. Most of what we will discuss will be above 90-day type of literature, though there's crossover in the literature as well, particularly around testing. We have nothing to disclose, and the presenters, Emily Thorell from Peds ID, Jared Olson, Clinical Pharm with Intermountain, who works with the ID team a lot, and myself, no relevant financial disclosures, no relevant relationships to disclose. And you might ask, why are we together on this presentation? Emily, Jared, and I have worked together in within the pediatric clinical program, the pediatric ID team, and we've worked on a number of CPMs together, and we have now a mutual interest in this watery topic. Pediatric UTI costs the U.S. healthcare system about $180 million annually. It accounts for 1.5 million clinician visits. It accounts for 5 to 10% of pediatric ED visits. It is not a small deal. It's estimated that 2% of boys and about 7% of girls will have a UTI before the age of 6. And accurate and timely diagnosis is important for two main reasons. One, there's a cascade of events that may or may not occur around imaging to assess the patient's physiology and anatomic predisposition. Secondly, there's implications around long-term renal issues around renal scarring, hypertension, end-stage renal disease. These last two bullets are not the focus of today's talk, and we will not wade into the quagmire of who gets imaged, how they should get imaged, how many urinary tract infections you should have, boys versus girls, fever versus not, blah, 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 ginger, blah, 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 ginger. That's for the urologists and all these societies to debate heatedly. How do we diagnose UTIs in children? This is a fascinating study and a little different than our typical clinical-based study because it's based on claims data. Within the United Healthcare System, a payer, and looking at from 02 to 07, and they had at the time 39 million subscribers, dependents in 50 states. And what they tried to get a handle on is who was diagnosed with a UTI, so they had to establish a definition of being diagnosed with UTI. Outpatient visit, diagnosis, that is a coding diagnosis of UTI. That got you into the study. You stayed in the study to demonstrate the physician's certainty, I guess, or devotion maybe to the diagnosis. You also needed an antibiotic prescription within 3 days before or 5 days after that clinic visit. So this is a claims data-based diagnosis criteria that gave us a group of patients, 40,000 patients, with the diagnosis of UTI. And what did we learn? Well, there were about 30,000 independent patients in that claims data over those 5 years. 90% were female, no huge surprise. But the first blow to my paradigm was that a urinalysis was only obtained in 76%. The second knife into my medical training heart was that a urine culture was only obtained in 57%. Who and on whom were these cultures obtained? Less than 57% actually had a urine culture obtained when an outpatient diagnosis was made. 2 to 5-year-olds, 61%, you can see the other numbers. Pediatricians were more prone to obtain cultures than, let's say, urologists. And remember, these are only less than 18-year-olds seen in an outpatient visit. If they had a urologic abnormality, you might surmise they might have been more likely to get a culture, but in fact, they were equally as likely to get a culture if they did not have a urologic abnormality or if they did. Males versus females, you can see there. The message is there is a lot of variation in how we practice, how we practice medicine at the academic center may not exactly reflect what's going on in the community, and some of our classic teaching about you must diagnose a UTI with a positive urine culture obviously is violated day in and day out across America, despite our efforts to make it great again. This is what I would consider the beginning of the very inquisitive set of studies that ask the question, gee, who has a urinary tract infection? And only in Philadelphia, perhaps, would they subject the children to what they did in this study. This study was published in '98 and occurred in a time period prior to that, obviously, but it was coming on the heels of a concept that was called occult bacteremia. That is, we couldn't figure out which febrile patients in the emergency department had bacteria in their bloodstream. And these investigators, Kathy Shaw and her colleagues, particularly one of her colleagues in Philadelphia, Mark Gorlick, they started a series of studies that tried to identify, well, is there this thing called occult urinary tract infection? That was really their purpose. To figure this out, you can't just look at patients that had UAs and urine cultures. You had to cath everyone. And basically, that was the design of the study. So there were a lot of screaming children in Philadelphia during these years. 2,400 children, and the entrance criteria was simply you had to be less than 12 months, boy or girl, or less than 2 years if you were a girl. So all boys less than 1 year, all girls less than 2 years got a cath as long as they had a fever over 38.5. Not your typical study, but they did get consent and go through the IRB and the usual stuff. They excluded certain patients, but most importantly, if you had antibiotics previously, if you were immune compromised, certain things got excluded. And for all of the clinicians in the audience, they cathed everyone, and by that I mean everyone. It didn't matter what your diagnosis was unless you had a definitive source for the fever. But they went on to describe the definitive source to the fever. Now, I'm going in great detail in this study because it really sets the stage for the rest of the presentation. So what was considered a definitive cause of fever? Well, it was definitive. Clinical evidence of cellulitis, adenitis, proven osteo, chicken pox based on exam, Coxsackie pharyngitis, on and on and on. Any positive culture that was known ahead of time was considered definitive. Positive strep was considered definitive. Many of the whiffy diagnoses that we make in the emergency department, gastroenteritis, otitis media, pharyngitis, things like that were not considered definitive. Those were potential infections. So this means that during this time period, every kid with a fever with otitis media in these age groups and these gender differences were cathed. You might respond with the simple phrase, yikers. What did they find? Well, they found out there was a lot of occult UTIs. Not a lot, but some, 3.3% overall. Whites more commonly in their population at 10%, girls more common than boys, uncircumcised males, higher percentage at 8% over girls overall. Those who did not have a potential source for the fever, that is, those without a potential source, didn't have otitis, didn't have gastroenteritis, they had a slightly higher rate than the population overall at about 6%. Certain things that clinicians had focused on, in fact, did increase your risk of UTI. Past history of UTI increased your risk, malodorous urine, ill appearance, abdominal tenderness, higher fever increased your risk. And overall, which was astounding at the time, white girls had the highest rate overall. In Boston, they duplicated this with a different methodology. They basically didn't cath everyone, but they looked at everyone in whom urine was obtained and looked at 11,000 urine cultures and basically used this for two purposes. One, to outline the prevalence by age and gender and race of urinary tract infections, but also they gave us some interesting data about the urinalysis, which Emily's going to cover with some other studies. I just want to highlight this study really supported our impression that urinary tract infections were much more common in the less than 3-month age group, and there was a steady decline in the prevalence of urinary tract infections as you got older. The three different bars are all with the diamonds, and you can see the female with the boxes are the top out to the right, but boys and girls have a very similar rate, a similarly high rate in the less than 3-month age group. That's partly why we treat them the same. And this was part of the impetus for us to treat them the same. They further broke this down by gender and race, and I don't want to go through details on this, but as you look at these individual groups, and let's focus as an example on white children, younger white children, and start at the upper left, younger white children had a prevalence of 6.5%. As you get older, over 6 months, then over a year, then over a year and a half, you can see the prevalence decreases as was illustrated on the other graph. But for every age group, as the temperature goes up, the prevalence increases too. So, when Gorlick and Shaw re-looked at their information, they tried to give us a little more guidance and actually created a prediction rule and the key elements that they thought we clinicians should focus on to determine who is at risk for urinary tract infection. And given that you were a girl and you were less than 2 years of age and you did have a fever, the other factors that were deemed important with the highest association with UTI might be younger age, white race, temperature over 39, fever of greater than 2 days duration, and no identifiable source for fever. And this is the data that really prompted people to adopt the practice they have now. The more variables in this associated variable list, the more likely it was you had a UTI. They were able to decrease their cultures overall when they applied these prediction rules retrospectively. Then Dr. Sheikh put together all the previous data leading up to 2007, including the Shaw data that I've covered, and gave us an overall prevalence of males and females by age, and you can see male infants have a high prevalence, 8.7%, female infants 7.5%, and then as you get older it goes down, but even girls less than a year have a higher prevalence than girls 1 year to 2 years. And what she went on to do is combine all the data about clinical features that I outlined in the Gorlick-Shaw study and combine all the data about prevalence and do what we always try to do clinically. We try to put people in buckets about possible risk. We do this for almost all conditions, and I describe it like having the scale of justice, and little tidbits come in and the history, the physical, and the lab studies, and we start tilting as clinicians. And intussusception is more likely, less likely, based on what they just told us. Then we do the exam, more likely, less likely. We look at the age, more likely, less likely. And eventually we tilt to the point where we do a diagnostic study. But this exactly outlines the way clinicians think, which I think was the main contribution of this meta-analysis. So you can see uncircumcised boys start with a probability of about 6%, and given the prevalence of some of these associated factors, you can decrease that to less than 2% if they have none, and the more factors they have, it might go up to 10, 20, even 25%. If you're circumcised boy, then you start at a low risk, and you're going to stay at a pretty low risk, but the more factors you have, your risk will step up in a stepwise fashion. The same thing applies to girls, using the exact same criteria: history of UTI, fever greater than 39, duration of fever greater than 24 hours, ill appearance, suprapubic tenderness, and non-black race all increase your risk. So we weigh those factors and we try to assign risk. And then back to Philadelphia, the kids had quit screaming by this time, and Dr. Lavelle tried to institute a quality improvement project using these same risk factors and put it in the context that sort of mirrors physician thinking, provider thinking. That is, you've got females, you've got males, we know they have certain risks based on their age. Now let's look at associated risk factors. Depending upon the number of risk factors, you should consider screening, that is, do a urinalysis, or you should recommend screening, and they weight these differently depending upon boys, girls, circumcised, uncircumcised, and the number of factors that should push you. So I'm going to stop right there and turn it over to Emily, and we'll go on to diagnosis of UTI.
Thank you, Jeff. And thanks for that nice setup. We're going to switch gears just a little bit and talk about the diagnosis of UTI in children, and really focusing on kind of what the guidelines say and what we've found at Intermountain with our data. So UTIs obviously are difficult to diagnose, especially in children less than 2 years of age, as Jeff has outlined with our catheterization stories. The symptoms are very nonspecific. The urine tests are warranted, especially in children with typical UTI symptoms. And then in children with cases of unexplained fever, as we know, about 5% of children aged 2 to 24 months with fever of unknown origin will have a UTI. Oops. So obtaining a specimen, in toilet-trained children, it's a little easier. You can instruct them on what to do, or their parents, in obtaining a clean catch midstream void urine specimen. In untoilet-trained children, it's a little tougher. So we have our non-invasive methods. A lot of people prefer a bag specimen where you apply the bag to the perineum. However, it's wrought with problems, as about 85% can give us false positives. It's only reliable if it's actually a negative specimen. And then you can try a clean catch midstream void. However, it's time consuming and you get about a 26% contamination rate. Although there was a study in 2016 on infants less than 3 months of age where you do a little bladder massage and try to get the urine that way. And some people are having a little fun with that. The contamination rate did go down to about 16% with that study, only in boys. And then our invasive methods, we have our bladder catheterization, which is our generally preferred method, which has about a 95% sensitivity and 99% specificity when you compare that with the gold standard of suprapubic aspiration, which you can say is frowned upon these days, unless you're a urologist. So suprapubic aspiration has higher pain scores and lower success rates than bladder caths, probably because we're not trained to do that anymore. When we compare the urine collection, a lot of different guidelines. So there's the UK guidelines, the AAP guidelines, there's Italian guidelines, a bunch of guidelines. And this is a study or an analysis that kind of compared all the different guidelines. We say the AAP in children less than 2 years of age recommends bladder catheterization as our preferred method, although you can see there are other studies or other guidelines that recommend different things. And then we have to think about pyelonephritis versus cystitis. In young children, it's really difficult to distinguish between acute cystitis and pyelonephritis clinically. So the guidelines actually don't really do that. So they use a broad definition of UTI, which includes both, because a lot of those kids will have fever. In older children, it's a little easier. They can tell you their symptoms. In cystitis, mostly dysuria, urgency, frequency, some hematuria or incontinence. And the pyelonephritis really is a hallmark of the constellation of fever, chills, and flank pain. The studies we have to remember, the ones that Jeff went over and anything that you look at in the literature, really don't differentiate between pyelonephritis and cystitis, so that is kind of a limiting factor. But because of all of this, we do differentiate between those 3 to 24 months and those 2 years and older in our testing recommendations, also, which I'll go over. So urinalysis versus microscopy. So just to review, urinalysis is our quick dipstick test for nitrite and leukocyte esterase, the things that we look at most commonly for infection. Nitrite is a conversion of dietary nitrate by the gram-negative bacteria, so it does not work for gram-positive infections. Luckily, we mostly have gram-negative infections. It's highly specific, and it has a few false positives. But a dilute urine may give a false negative, so it's not recommended for young children who void frequently. The leukocyte esterase is a surrogate marker for pyuria, but pyuria, remember, is not specific for UTI, so false positives are common with other clinical syndromes. It's highly sensitive, however, and it's nice because it's absent in those with asymptomatic bacteriuria. Microscopy adds at the exam for white blood cells and bacteria. So the white blood cells are an indicator of inflammation associated with UTI, but again, not specific for that. And there's no standardized definition of pyuria in the literature. But generally, what's the usual threshold is 5 white blood cells per high power field. When we look at the urinalysis sensitivity and specificity of the different components, you can see, so the leukocyte esterase test has an overall sensitivity of 83%. However, it goes up to 94% when it's used in the context of clinically suspected urinary tract infection, and the specificity is lower. The nitrite test has an overall sensitivity of 53%, but it's very specific with an overall specificity of 98%. It's highly specific but less sensitive, since not all those bacteria are going to convert the nitrate to nitrite. And it also takes about 4 hours in the bladder for this to occur. So in infants, this is less useful. In the literature, when you take the leukocyte esterase plus the nitrite, it had a sensitivity of 93%. When you add those white blood cells in, the sensitivity increases to 99%, but the specificity doesn't really improve, which is likely reflective of the fact that white blood cells may be found in the urine for numerous other conditions. When we look at urine culture, obviously it's the gold standard and it's what we base most of our recommendations on. But even that, the interpretation of culture is different in the different guidelines. What's generally accepted is 50,000 colony-forming units per milliliter for a cath specimen, and that's what we use per the AAP guidelines as a positive urine culture. And then we also have to remember there's the asymptomatic bacteriuria, where children have a positive urine culture even at the colony counts where we would consider infection. But if they have a normal UA and don't have symptoms, then it's probably just bacteria that will self-resolve, and it's not an indication for treatment. When we looked at our own data here at Intermountain, we looked at the patients who had urinalyses and cultures collected at the same time in our own ED here at Primary Children's. That was over about a 15-month period in 2016 and 17. That was a little over 2,000 patients. All of these patients were cultured. You can see that 42%, that first graph, of the cultures were actually negative. You can see that an additional 53% were contaminants. You can see that 2% had cultures with greater than 50,000 colonies of a uropathogen, which is what we say is a urinary tract infection. But this doesn't take into account asymptomatic bacteriuria either, so the clinically significant cultures may actually be even less than that 2%. And then when we looked at all those patients, we compared those who had microscopy versus just the urinalysis dipstick. Of those over 2,000 patients with a negative dipstick for both leukocyte esterase and nitrite, about 216 had greater than 5 white blood cells per high power field, which is about 10%. But of those patients, only 7 had what we would consider a urinary tract infection with greater than 50,000 colony-forming units of the uropathogen. So that was just 0.3%. So we concluded that microscopy doesn't really add a whole lot of value for those patients in the emergency department with their initial urinary tract infection. We are also right now working on an I-Centra order to reflect this recommendation, but it's not there yet. So currently there's no reflex order for a culture when you have a positive dipstick, whereas if you had a negative dipstick, no culture. That's not there, but hopefully it will be coming. So we did a pilot in our emergency department with our care process. So basically, if you were 3 to 24 months old, you had a UTI or fever, you want to stratify by sex and risk factors, just like Dr. Schunk had outlined for us. Obtain a urine dipstick without microscopy and culture. We wanted culture in all those patients, given that we were catheterizing them. But if you were greater than 24 months, you could obtain your dipstick. If it's negative for leukocyte esterase and nitrite, no culture, obtain. And then if it's positive, go ahead and send your culture. And we did create some dashboards to follow this. In the PEDS clinical program, Karen, a shout out to Karen Valentine, who did all this work on our run charts. So as you can see, for microscopy testing, we had a paper chart, a paper order, initially. So you can see that we had a little bit of success with our no microscopy initially, but hopefully when we get an I-Centra order, this will get a little better. And then we're also monitoring urine culture testing. Unfortunately, this is actually reflective of 90 days to 18 years, so it should be 2. We need to change that to 2 years. But you can see that the cultures are actually going down a little bit. And then I'm going to leave a little more room for Jared to talk about treatment, which is the main portion of our care process.
Thank you very much. You guys are probably asking, where is this care process model published? It's actually currently not published yet. It's still in pilot in the ED at Primary Children's, but it is going through medical writing and it should be available soon. But what we'd like to go, I'd like to talk actually about the rationale for the decision of the empiric treatment in these patients. So why did we choose the drugs that we did? So here is a table that actually demonstrates the antibiotic recommendations from our pilot project for patients between the ages of 3 and 24 months. And actually our oral option that we're recommending for most patients is cephalexin, which is a first-generation cephalosporin, with a dose that's indicated here with a duration of 7 to 10 days recommended. The American Academy of Pediatrics recommends anywhere between 7 and 14 days, saying that there's no difference between those two regimens. And so we've actually tried to decrease the duration of therapy a little bit from the upper end of 14 days to 10 days in this setting. For patients with serious allergies to cephalosporins, we have some recommendations with some caveats. So trimethoprim sulfa is actually the recommendation in this setting for patients with severe anaphylaxis or hives or hand or lip swelling or respiratory distress, these type of allergies to cephalosporins. And you can see that only 70% of our E. coli isolates are susceptible to that regimen. And so it's really important to take that into consideration when making recommendations for these patients with serious allergies to cephalosporins. Some other opportunities and for non-severe allergies to cephalosporins, we've actually recommended amoxicillin and clavulanate in this population. About 88% of our E. coli, which is the predominant pathogen that we see in urinary tract infections, more than 80% of the time, and 88% of them are susceptible to augmentin. If we're admitting a patient, we've recommended intravenous ceftriaxone at the dose indicated with the goal to transition over to oral therapy as soon as possible and clinically indicated. For patients with serious cephalosporin allergies, we recommend gentamicin in that setting. For patients greater than 24 months, we've actually made some significant changes to the recommendation. You'll first notice that we've distinguished between uncomplicated UTI and cystitis, where we actually recommend cephalexin again, but a 5-day duration for acute cystitis. And then there's different recommendations for patients with pyelonephritis. For those patients that are 2 years to 12 years, we are still recommending cephalexin as the primary agent. But for patients greater than 12 years of age, we're actually giving an option to use ciprofloxacin, which is a fluoroquinolone that's used predominantly in adults for pyelonephritis. And it actually has a very good track record for that disease state. And we'll talk a little bit more about fluoroquinolones in kids towards the end of this discussion. But we do still have an alternative, which is cephalexin for those patients that are greater than 12 years as well. All right, so I think let's ask a question, guys. So a 10-month-old patient was sent home with an appropriate dose of cephalexin for pyelonephritis. The urine culture results are back, and the susceptibilities are back, and we have E. coli, and the susceptibilities are shown. It's susceptible to amoxiclav, cefazolin, ceftriaxone, nitrofurantoin, but it's resistant to cephalithrin, trimethoprim sulfa, and ciprofloxacin. Did you get it? The question is the empiric antibiotic appropriate? Can you guys raise your hand for yes? If you guys think that was an appropriate, all right, great. So many people answered yes in this setting, and those of you who may have answered no, actually, might actually remember something kind of interesting. So I want to make sure that you guys remember that not all first-generation cephalosporins are the same. Historically, we've actually used indicator drugs to predict first-generation cephalosporin susceptibility. And historically, we used the drug cephalithrin as the indicator drug. And many of you may actually remember that as the indicator drug for cephalexin, excuse me. It turns out in studies that cephalithrin is a very terrible predictor for cephalexin activity. And so as you can see, this is an antibiogram that we had here at Primary Children's when we were using cephalithrin as the indicator drug. And you can see that the susceptibility rate for cephalithrin is lower than amoxicillin or ampicillin, and it was at 30%. And so really some of the, historically speaking, first-generation cephalosporins weren't, because of the indicator drug, we really kind of questioned whether or not they were going to be efficacious for urinary tract infections. The Clinical and Laboratory Standards Institute actually has changed these recommendations based on the poor predictive value of cephalithrin, and now recommends using cefazolin as the predictor drug for all oral cephalosporins. So it states, exactly, cefazolin results are used to predict results for the oral agents cefaclor, cefdinir, cefpodoxime, cefprozil, cefuroxime, cephalexin, and loracarbef. And cefazolin as a surrogate, it is noted that it may overcall the resistance rates to cefdinir and cefuroxime it turns out that it's about 1% different. And so there are some times when we'll say that cefazolin is going to be resistant, but cefdinir may be an option, but that's 1% of the time. So as we've accepted cefazolin as the surrogate for all, again, oral cephalosporins, this has also allowed the Primary Children's Hospital lab to use a pre-made susceptibility card rather than performing the Kirby-Bauer on urine isolates. All right, and this is our antibiogram from 2017, and you can actually see that the cefazolin susceptibility rate for our urine isolates is 96.95%. And you can see that cefdinir is just a little bit above, and it's 1% higher when we still are, when we do a Kirby-Bauer on cefdinir to find out if it is susceptible. And so really, we have a very good likelihood that cephalexin and cefazolin is going to be working. And so we're really excited about that for our E. coli isolates, which is fantastic. So this, along with some antibiotic stewardship principles, led us to really choose cephalexin as the primary agent for our patients with UTIs in these age groups. So some of the stewardship principles that we try to adhere to include making sure that we have adequate therapeutic efficacy, and so that's really important, making sure that we have efficacious drugs that we're initiating on these patients. But we also want to have the drug that has the lowest risk for facilitating antimicrobial resistance. And we also want to use the drug that has the lowest likelihood of promoting Clostridium difficile and other adverse events associated with the drug therapy. We also want to take into consideration healthcare value. So when we were looking at this, when we were implementing this pilot project in the emergency department here at Primary Children's, we were looking at cephalexin versus other cephalosporins, and the predominant cephalosporin at the time that was being used was actually cefdinir in our population. There are no comparative outcomes prospective studies performed, and there aren't any studies that actually suggest any differences in outcome between oral cephalosporins in children. We reached out to our colleagues from around the nation, and many people were using cephalexin as the primary agent for their UTI, first onset UTI patients. The reasons being, first, generation cephalosporins are less broad and also will hopefully decrease the risk of antimicrobial resistance and C. diff. Cefdinir, actually only 20% of the drug is absorbed into the body, and the rest, the 80%, just stays in your stool and interacts with all of your microbiome, for that time period, and so has a dramatic, we imagine, impact on the microbiome of an individual. Whereas when you look at cephalexin, more than 90% of the drug is actually absorbed in the populations that we're making the recommendation in. So that absorbed drug does its job and is excreted in the urine and has a fantastic effect for the UTI, but minimizes also the drug exposure into the colon, where many of our organisms and that cause UTIs are harboring. The healthcare value question was also asked, and when we initiated this project, there was a dramatic cost difference between oral cephalosporins, and it really favored cephalexin. The cefdinir suspension cost when we first initiated was $60 to $90 per bottle, and there was a cost savings of $30 to $50 per prescription by using cephalexin, and that was a pretty exciting cost savings. Well, although drug prices are increasing, actually cefdinir cost actually did decrease over the last time period. Although published prices, when they're describing average wholesale costs, are actually still what we had reported and seen in the beginning of our project. The current cost, when we looked at select health pharmacy benefits prescriptions, and anybody can do this, it's actually equivalent. The suspension of cephalexin to cefdinir now for equivalent duration of therapy and an equivalent treatment course is actually pretty similar. However, they're both significantly less expensive than cefixime. And so the take-home point is we really do prefer Keflex for the preservation of our human microbiome, but we're really not having the same cost effect that we had initially in our project. When you look at the cost considerations of the drugs when we're using solid dosage forms, there still is about half the cost when you're using cephalexin versus using cefdinir when you're talking about the oral dosage forms that are solid, so capsules. Cefixime still is dramatically more expensive, and even more so when you're talking about the solid dosage forms. If you guys, this next slide is just here for your reference if you'd like to see the actual costs currently for those drugs. So another interesting finding or suggestion that we're making is fluoroquinolones in pediatric patients. And I know that we've talked a lot about fluoroquinolones over the years and how we should really try to avoid them for most settings in pediatric patients. So I wanted to ask you guys a question. We have a 6-year-old patient who was prescribed cephalexin for pyelonephritis. The urine culture is back today and is positive for greater than 100,000 colony-forming units per mil of Pseudomonas aeruginosa with the susceptibilities as shown. Is oral ciprofloxacin a reasonable consideration to avoid intravenous antibiotics at home? Raise your guys' hand if you guys think that, yes, it's a reasonable option. Fantastic. Yeah, we really do believe that it is a viable option. We'll talk about that a little bit later. I wanted to highlight another key point, though. If this culture said actually that it was greater than 100,000 CFUs of a non-lactose fermenting gram-negative bacillus, how many of you guys would change to ciprofloxacin in that setting? Raise your hand if it's a yes. Okay, we don't really have many people. And what I wanted to highlight was actually when it's a non-lactose fermenting gram-negative bacillus that you're seeing from a urine culture in a patient without risk factors for Pseudomonas, it's actually very likely that it could be E. coli. And about 10% of our E. coli are what we call late lactose fermenters, and it takes a little while. And so if you do have that ever happen and you're concerned about the patient, you want to make sure that you have the right drug on board for the patient, please consider giving our call to our microbiology lab. They can use other tests to help you identify whether or not it truly is Pseudomonas. And this happens more frequently on the inpatient side than on the outpatient side, I think, but it does occur occasionally, and wanted to kind of highlight that opportunity. All right, let's talk about ciprofloxacin for children. Fluoroquinolones have an important but really a limited role in treating children with infections. Early studies in animals demonstrated that there was cartilage damage at therapeutic doses that are used, or similar doses that are used in humans. However, to date, no child treated with fluoroquinolone has developed physician-documented long-term bone or joint toxicity. That being said, there are retrospective studies suggesting that there are increased rates of complaints of joint problems when they are taking fluoroquinolones compared to other beta-lactam antibiotics. However, those are not permanent, and they resolve after therapy is done. And there is some question about the design of the study and recall bias just because they were told that they might have those when they were getting the fluoroquinolone. So just to make sure you know that. The FDA has approved ciprofloxacin for the use of children with pyelonephritis, and so there is an FDA indication for it. And it's really an option for drug-resistant UTIs in order to avoid IV antibiotic therapy at home. And it's really our only oral option for Pseudomonas aeruginosa, the fluoroquinolones. We wanted to emphasize, though, that we're not recommending it for empiric treatment of uncomplicated acute cystitis. You should use alternatives. There are lots of alternatives for the initial therapy of uncomplicated acute cystitis, and the American Academy of Pediatrics has a strong statement against using fluoroquinolones in that setting. Adult guidelines for pyelonephritis actually do recommend using and really saving fluoroquinolones for pyelonephritis, and they recommend them over using beta-lactams. So there's some data in adults that suggest that their efficacy may be a little bit greater than the oral cephalosporins that we commonly use when you're dealing with adult patients. And so really, these reasons actually led us to list as an option for patients greater than 12 with pyelonephritis, ciprofloxacin as an alternative. So I wanted to make sure you guys knew that. All right, so when we've looked at our run charts, actually, we can actually see in the ED at Primary Children's, you can actually see that here's a chart right here. This is the proportion of patients receiving antibiotics that are getting cephalexin as the primary treatment choice, and you can see that it was very low in 2016. We started talking about this, and it started to increase, and now we're actually, the majority of patients are getting cephalexin for the treatment of UTIs at Primary Children's. We've actually followed some balance measures to make sure that we're not causing harm, and we performed a retrospective analysis on the first 3 months of therapy and saw no difference in patients' representations to the ED or also changes by phone call of the physician from the ED to the family. And I don't have those slides here today, but had a little more time to talk about that than I had anticipated. All right. Thank you very much. As with any project, it required a huge team, and we wanted to make sure that we acknowledged all those individuals that were involved, and wanted to also acknowledge the ED here at Primary Children's and thank them for their willingness to pilot this project. We plan on implementing this project throughout the institution, throughout all of Intermountain. Very soon, we're waiting for some medical writers to finish up the draft to beautify the document so it can go out to the rest of the Intermountain world. Thank you very much for your time today, and we're ready for questions.
That one slide shows that physicians really can change, even ED physicians. Any questions?
That's sort of the med-peds question, which is in post-menarchal women, UTIs really are similar to adult UTIs, and you can discriminate between acute uncomplicated cystitis and pyelo more readily. I'm wondering why you didn't specifically call out women 13 to 18.
So the question is why we didn't discriminate between women aged 13 to 18 and others. I mean, it's definitely something that we could do. I think we wanted to start out and see where we are, and we'll look at our data, but that's a great suggestion. And we did have the 5-day suggestion for acute cystitis for those patients that would fall into that category. But I mean, in the adult literature, it's even down to 3 days, so we could do that.
Hi, I'm Karen. I had a question about nitrofurantoin macrobid as an antibiotic choice as a possibility, because it looked actually good up there,
Yeah.
and that was.
That's a great question. Yeah, and so actually, and Andy just brought that up as a great option, and actually it is an option for acute cystitis and for patients that are greater than 12 years of age. Really one of the problems with, so it's a great drug and it works really well when you're dealing with acute cystitis. The blood concentrations are actually not measurable of the drug. And so if you're dealing with a pyelonephritis, where blood concentrations really probably are important, you don't want to use nitrofurantoin as your drug. However, it's a great option for acute cystitis. A treatment course is 5 days. And we did discuss whether or not we wanted to use that as a primary agent in our protocol. The decision was made to make it simple and to use Keflex for everybody. The resistance rates actually for nitrofurantoin are very small for E. coli, and so it is a really good empiric agent and even it can be used for some drug-resistant pathogens actually. So it is an option for acute cystitis, but we wouldn't recommend it for pyelonephritis at all. And in patients less than 2 years of age, we assume that they have pyelonephritis. There's no distinction between pyelo and acute cystitis. So, yeah, thank you. Does that answer the question?
Am I remembering that it's expensive?
It is. The liquid formulation is quite expensive, and that did weigh into whether or not we were going to recommend it.
Any hope that we can do Keflex and BID instead of TID dosing? That's like the one thing every time I write it, I think, 3 times a day in an 18-month-old. Anyway, any hope that there's concentrations great enough for BID?
Awesome question. For acute cystitis, BID dosing is totally fine. You're really worried about urine concentrations. 100% of the drug is eliminated in the urine, and so that's fine. However, for pyelonephritis, where we're worried about blood concentrations of the drug, we didn't feel comfortable making that recommendation given the pharmacokinetics of the drug. Actually, many institutions are using 4 times a day dosing, and so the 3 times a day dosing is actually is a little bit better than the four times a day. So at least we're not doing 4 times a day is what I'm saying. So if that's any consolation.
I have a question, came from Miguel Nochel online here. If you start a broader spectrum oral antibiotic such as ciprofloxacin or ceftonir, and the susceptibilities come back susceptible to Bactrim, Amox, or Keflex, should you call the patient, have them go to the pharmacy, and switch to the narrower antibiotic?
All right. I guess this is a question for me. Yeah, so we, once the prescription's been dispensed and you've started the drug, we're not making the recommendation to change. We do think it would be appropriate if the patient doesn't meet the criteria for a UTI and they have a urine culture that's negative. We do think it's appropriate to give them a call and to consider stopping the antibiotic. However, we're not making recommendations to change and to write another prescription to narrow the therapy. However, on the inpatient side, oftentimes you'll have susceptibilities. Please use those and use the most narrow agent possible that you can in order to treat the UTI. But on the outpatient side, it's really not an economical opportunity.
Not to mention the fact that then there won't be those old prescriptions laying around that people might think to start.
Excellent, excellent observation.
Why is the oral first line a first generation, but the IV first line is a third gen? Why couldn't we use cefazolin as a first line IV?
Excellent question, and we debated this topic actually, and you could use cefazolin as an your empiric choice on the inpatient side if you really wanted to. The difference between, so although the difference between ceftonir and cephalexin, there's not really a very big difference in the susceptibility. Ceftonir, although it's a third generation cephalosporin, is not ceftriaxone. Ceftriaxone does pick up some organisms that cephalexin doesn't, and so although it's very few organisms, we had made the recommendation to use ceftriaxone just because you do pick up a certain percentage. It was somewhere around 3 to 5%, depending on which susceptibility antibiogram we wanted to look at. And so just given that they were being admitted and they were starting on IV antibiotics, we thought that ceftriaxone would be an easy one. And also, although this didn't play a huge role into it, it's actually more cost effective than cefazolin as well.
Is there wiggle room on the recommendations for admitting a patient on oral antibiotics? Sometimes we admit them because they're dehydrated or...
Yeah, so you can. There's a great study by Holderman that actually suggested that cefixime versus ceftriaxone in patients that were, I believe it was 2 months to 2 years, there was no difference in outcomes if you used oral antibiotics. So that is permitted. We haven't, and it's fine. We didn't make a big distinction in the algorithm for that. We just said if you're going to use IV therapy to use ceftriaxone, but if you want it to be more clearly delineated, we can do so. Why don't we ask some questions to the other presenters, guys?
This one's actually for Emily. At some national conferences that I've been to recently, I've heard more and more people recommend sort of a staged approach to doing the diagnosis, where you do a bagged sample first, and if it's negative, as you said, you can rely on that, and then you can just stop there, and if it's positive, then you follow it up with a cath UA. I realize that's not convenient for the ER where patient flow is important, but I was just wondering if you could comment on that.
Yeah, I think the question is, could we do a more staged approach to diagnosis where you could get a bag? I think, if you're in an office setting and things are not crazy with respiratory season and you don't need to get them out, you could definitely do that approach. If you've got a good family that you have well established with and you can call them and they know that there may be a little bit of a risk here to wait, I think that's totally appropriate. But this was our ED pilot, so we didn't think that was going to fly.
And excellent question. In the Lavelle study, it was a two-prong. They listed the clinical criteria for which you should do a screen on the urine, but they also allowed for an option of a bag specimen in the ED. And they did, of course, decrease their number of caths, and they did do the UA off the bag specimen. So it's not heresy by any means, unlike some of the other things we've said, perhaps. I think we'll probably wrap it up there. I would like to thank Emily and Jared for their help. And I forget whose quote it was that 90% of life is just showing up. But in Jared's case, it's 90% is just showing up and learning how to pronounce the cephalosporins. So that's why he had that portion. And thank you for your attention.